we have evaluated potential biological frailty markers in both elderly and young persons because many biomarkers have been studied in geriatrics as biomarkers of frailty, but oncogeriatrics is the oncological patient is still it's not it has many differences with respect to the general geriatric patients. So findings from general geriatrics cannot be extrapolated and just applied to the oncological patients. We focus mainly on the immunitary aging, so immunosenescence and inflammaging. Telomere length in leukocyte, which can be a marker of immunosenescence because leukocytes tend to be less active in the elderly. The CD8-CD4 ratio is altered. And so we wanted to see if relative telomere length in leukocyte shortening of telomere length could correlate with frailty. Yes, there are also other biomarkers, interleukin-6, MCP1 and RANTES, and IGF-1. Which is a molecule involved in the insulin IGF growth factor pathway, which is altered in the elderly. We correlated them both with chronological age and with global health, clinical global health, that we measured mainly by comprehensive geriatric assessment, all the subtests of the comprehensive geriatric assessment. Not all of them. All the biomarkers except RANTES correlated with chronological age, but only interleukin-6 correlated with frailty, with clinical frailty. Not really a molecular signature because just one of the molecules correlated with frailty in our study, so we couldn't make a sort of signature. Because telomere length correlated only with chronological age as well as the other molecules except interleukin-6. RANTES did not correlate neither with chronological age and with frailty, so we just had one biomarker of frailty, and that was significant, interleukin-6. It's too early because in our study, it is true that in our study interleukin-6 correlated with frailty, but we still don't have a cutoff. So first we will need to do further research, focusing now just on interleukin-6, and then try to find a cutoff for frailty for that molecule. So now it's still not ready for the clinic. However, it will be useful in the future to have frailty biomarkers in the clinic, easily measurable in blood, because comprehensive geriatric assessment is now the clinical gold standard, but it doesn't have a validated N-score, and it takes 45 minutes to be performed. Now we're looking also at other biomarkers in other projects. Well, it will be very useful to find molecular biomarkers, because then a patient wouldn't have to come for another visit for a geriatric evaluation, or biomarkers could be additive to geriatric assessment. In this study, interleukin-6 was not additive to comprehensive geriatric assessment. They were the same, but we don't know if interleukin-6 or also the other biomarkers could be predictive of death during chemotherapy, of short, long-term toxicities, we're doing it in another project, and that would be interesting, and it would be useful in the clinic. Could be predictive of toxicity, but we still don't know. We're evaluating it now. We're doing another study of biomarkers during chemotherapy follow-up, both plasmatic inflammatory molecules and microRNAs. I've just finished a microRNA experiment, and I'll start the analysis, gene expression, but we still don't have the results. The majority of cancer patients are older than 70 years, especially breast cancer patients, because breast cancer is a disease that increases with age, and life expectancy is increasing as well. Treatment options, making a treatment program for an elderly patient is very often challenging for the clinician, because frailty patients could have more toxicity during cancer chemotherapy, and it cannot be done solely based on chronological age. And you can distinguish between very fit and very frail old patient, but there is the in-between gray zone that is very difficult to set. And then there is a clinical method, which is the comprehensive geriatric assessment, but it's time-consuming. So the research we're doing is due to give the clinician more easily and fast ways to assess frailty in order to make the best decision for patients and avoid over-treatment or under-treatment, which is what frequently happens more in elderly patients with breast cancer.